Hello and welcome to the video lesson on anatomy of the upper extremity. We're going to talk about first the wrist and hand anatomy. There are 27 bones that comprise the hand and the wrist, and it's 12 phalanges in each hand, 5 metacarpals in each hand, as well as 8 carpals in each wrist. Taking a look at this picture, we can see that there are 5 distal phalanges, starting off with the first digit going to the 5th. Then we have the 4 middle phalanges are only found in the 2nd to the 5th digits. The proximal phalanges are found in the 1st to the 5th, so there are 5 of them. And then we have the metacarpals, which are shown here in green, and that comprises the palm of the hand. And then down here in the brownish color are the carpal bones, and there's a total of 8 of them. So the 5 digits have 2 or 3 separate bones called a phalanx. The thumb has 2 of them. It only has the distal and the proximal, but as shown here in the picture on the right, the fingers, the 2nd to the 5th anyway, have 3 phalanges. There's the distal in yellow, the middle in red, and the proximal shown in blue. Each phalange has a head, a body, and a base, just like the metacarpals do as well. And so the image on the left-hand side is of a 2nd digit, so we can see this, the distal phalange, the middle phalange, and then the proximal phalange. And then on the thumb, we can see that it only has a distal phalange and a proximal. The bone that's down here, that is the first metacarpal. The 5 metacarpals make up the palm of the hand, and that first metacarpal is going to articulate with the first digit. So that's the first digit here. Over here, going from first, then starting with, over to 5, there is how the fingers are numbered. And keep in mind that again, that the metacarpals have a head, a body, and a base. And the base is a broader area that's going to articulate with the carpal bones, specifically the distal row of carpals. The first digit, called the thumb, has an interphalangeal joint, which means it's going to be between 2 phalanges. That's between the distal phalange and the proximal phalange. The other interphalangeal joints are not called just ips, they're called dips and pips. So these are the dip joints, distal interphalangeal joints. And then we have the pip joints, which are called the proximal interphalangeal joints. And they're named, as we'll talk about the next slide, as to where they're located. We also have in blue where we have the metacarpal phalangeal joints, and that's located between the metacarpals and then the proximal phalanges, the bases of the proximal phalanges. The dip joints are the distal interphalangeal joints, as mentioned before. So they're going to be located between the distal and middle phalanges. We have the, oops, that's misspelled, excuse me, phalanges. And then we have the pip joints, which are located between the proximal and middle phalanges. The carpal-metacarpal joints, which are the CMCs, are located between the bases of the metacarpals and the carpal bones, specifically the distal row. The intercarpal joints are located between the carpals. And then there's the radiocarpal joint, which is located between the carpals and the distal radius. Now that specific joint is between the radius and the scaphoid and the lunate. That's going to be forming the radiocarpal joint. Now let's talk about the carpals. We have a proximal row and a distal row of carpals. Starting on the lateral side, which is where the thumb is, we have the scaphoid, then the lunate, triquetrum, and then the pisiform. That forms the proximal row of carpals. Starting from the lateral side again, on the distal row of carpals, distal being further away, are the trapezium, trapezoid, capitate, and the hamate. Let's talk about each one of those. So from the radial side, which is the lateral side again, that's the thumb side, the radial side, we have the scaphoid, which is the largest in the proximal row. It has a tubercle in the anterior and the lateral aspect for muscle attachment. The lunate is the second one. It's going to articulate with the radius also, just like the scaphoid did. It's crescent shaped. The triquetrum is pyramidal in shape, and it articulates anteriorly with the hamate bone. And then finally, we have the pisiform, which is the most medial or pinky side carpal in the proximal row. It's a P-shaped bone that's situated anterior to the triquetrum and is easily palpated. From the radial side again, which is again the lateral side, otherwise called the thumb side, is the trapezium, then the trapezoid. And the trapezium has a tubercle and groove on the anterior surface. The trapezoid is a smaller surface anteriorly than the posteriorly. The capitate articulates with the base of the third metacarpal, and it's the largest and most centrally located carpal. And then finally, we have a wedge-shaped carpal called the hamate, which is on the pinky side or the medial side in the distal row, and it has a hamulus. And so a humulus is a hook-like process on the anterior surface. Here's a mnemonic that you can use if you would like, and then also just a review of in the proximal row that we have the scaphoid, the lunate, triquetrum, and pisiform. In the distal row, keep in mind that trapezium and trapezoid are very closely spelled all the way up to a point. But trapezium comes before trapezoid in the alphabet, so trapezium first, then trapezoid, then capitate, and then hamate. The trapezium is what articulates with the base of the first metacarpal. The carpal canal, otherwise called the tunnel, encompasses a carpal sulcus. That's a concave anterior surface of the carpal bones. There's a carpal canal that will, here's the carpal sulcus to which they're referring. The carpal canal is the passageway between the carpal sulcus and the flexor retinaculum. The median nerve and the flexor tendons pass through the carpal canal, and here's the median nerve to which we're referring again. And then CTS is a common problem called carpal tunnel syndrome, and it's a result of compression of the median nerve. Now, looking at the joints of the hand and the wrist, the interphalangeals, whether we're talking about the dips, the pips, or the ip, they're all hinge joints. They only flex and extend. The carpometacarpal joints and the radiocarpal joint are both ellipsoidal. They do flexion, extension, abduction, and adduction. The only saddle joint that we have in the body is the first carpometacarpal joint, and it does flexion, extension, abduction, adduction, circumduction, opposition, and rotation. Then we have the second to the fifth carpometacarpal joint, which is the intercarpal, and that's considered a gliding joint. And there's slight flexion extension and extension with this one. And this is just showing the joints again. In red are the distal interphalangeal joints, the dips. In navy blue are the proximal interphalangeal joints. The interphalangeal, they didn't put a color on it, so I'll just circle it. The green are the metacarpal phalangeal joints. We've got the yellow showing the carpometacarpals, which are the CMCs. In pink, we have the intercarpals, and then the radiocarpal shown in orange. Now the forearm has two bones. The one on the medial surface is the ulna. So the ulna has a proximal end, a body, and a distal end, just like the radius will too. On the proximal end, we have the biggest end for the ulna. It's the olecranon process is found posteriorly. The coronoid process projects anteriorly and curves slightly superiorly also. We have the trochlear notch, which is going to be a concave depression. It's going to hold the trochlea from the humerus. And then we have the radial notch, which is going to allow the articulation with the radius. There's the body or the shaft of the ulna, and then on the distal end is the head of the ulna. So the head of the ulna is on the distal end of the bone on the lateral side. There's also an ulnar styloid process, which is a conic projection on the posterior medial side. Now the radius is the opposite in that the head is in the proximal end. So and the larger end of the bone is going to be on the distal end. So it's the opposite of the ulna. So the proximal end has the head, which is a flat disc-like shape. It's going to articulate with the capitulum of the humerus. The neck is the constricted area distal to the head. And then we have the radial tuberosity, which is important for positioning purposes, and it's going to be a roughened process that is inferior to the neck and on the medial side of the body. There's the distal end, which is broad and flattened and larger than the proximal end, and there's another styloid process, another conic projection. It's on the lateral surface, just like there was on the ulna as well. On the distal humerus, we have a humeral condyle. The humeral condyle has smooth elevations for the articulation with the bones of the forearm. It's got the trochlea that's on the medial side, and it's got the capitulum on the lateral surface. So the capitulum articulates with the head of the radius, the trochlea articulates with the trochlear notch of the ulna. So the epicondyles are going to be above the condyles. They're proximal to the condyles. So here's the medial epicondyle is a larger pointed process, and the lateral epicondyle smaller. And it's a sharp process as well. We have some depressions on the anterior surface. Those are the coronoid process. It's a shallow depression superior to the trochlea that receives the coronoid process. So there's the coronoid fossa. And then we have the radial fossa, which is shown here. That's a small depression that receives the radial head, and it's proximal to the capitulum. On the posterior surface, which we cannot see, is the olecranon fossa, and that's going to allow the olecranon process of the ulna to go into that groove or into that depression when the elbow is extended. Now, as far as joints are concerned, we have two pivot joints and two hinge joints that we're going to take a look at. The first one is the distal radial ulnar joint. That's the joint between between the radius and the ulna on the distal end. It's a pivot joint. And then there's also an articulation between the radius and ulna on the proximal end close to the elbow, and it's also a pivot joint. Now, on the other hand, we have two hinge joints. Between the humerus and the radius, we have a hinge joint. And between the ulna and the humerus, we have a hinge joint. So there's only flexion extension happening with our hinge joints. Fat pads are accumulation of fat around joints of the upper and lower extremity. They're radiolucent. If there is injury, such as to the elbow, it would cause effusion, which is bleeding, and that disperses the fat pads and alters their shape. They also show up more obviously shown more radiographically. So there's going to be some indicator of elbow pathology if they're visualized. Wrist fat pads are seen on PA oblique and lateral projections. We'll see in a couple slides ahead. There's a scaphoid fat pad and a pronator fat pad. The scaphoid fat pad seen on the PA in the oblique, and the pronator seen on the lateral. We also have, which are very important to us, are the elbow fat pads that are visualized on the lateral projection. We have an anterior fat pad, which lies in the coronoid and the radial fossa of the anterior humerus, which makes sense, it's anterior. Posterior fat pad is going to be located in the olecranon fossa of the posterior humerus. So again, it goes along with its posterior. And then there's the supinator fat pad, which is located anterior and parallel with the anterior aspect of the proximal radius. Looking at the image on the left-hand side, we don't see the location of the fat pads, but on the right we do. So there's the supinator fat pad that we just discussed. There's the anterior fat pad, and the posterior fat pad of the elbow. Again, shown on the lateral projections. So in the images shown here, we're taking a look at the fat pads of the wrist. And then here's the fat pads, again, the posterior at letter D, the anterior at letter C, and letter E is the supinator fat pad. Here's an image showing when a person has a fracture or pathology of some type, which is usually a fracture, the fat pads do visualize. This is the anterior and this is the posterior fat pad, and they are visualized. They didn't point it out, but even the supinator fat pad's showing up as well. The last thing to talk about is the proximal humerus, and that is that we have the head of the humerus. The head of the humerus, which can be seen in different images here, is going to be the large, smooth, and rounded area that articulates with the scapula, specifically with the glenoid cavity. The other thing that we have is going to be we also have is the anatomic neck. The anatomic neck is that area that's real close to the head. It's a constricted area just below it, but it's located, kind of hard to see this color. Let me change that color there. It's constructed just right beneath the head. In fact, it's a little bit lateral to the head, but it's below it. Then we have the surgical neck, which is down here. The difference between the anatomic neck and the surgical neck is the surgical neck is a constricted area below the tubercles, and it's a site of fractures where we commonly see individuals needing surgery, hence surgical. Then we have the next part, looking at continuing on with this, we have the lesser and the greater tubercles. The greater tubercle is going to be the part that's going to protrude laterally. It's on the lateral surface that's below the anatomic neck. And we have the lesser tubercle that's on the anterior surface, and it's located just below the anatomic neck. So it's on the anterior surface. This one's a little bit harder to see. And then this one shows it on the anterior surface here. And then there's an intertubercular groove, which is a groove between the two tubercles, just shown here, or you can see it also here. So it's a groove that's between the two tubercles. And they show the groove as well on this projection, this viewpoint as well. So that concludes our lesson on anatomy of the upper extremity. Have a great day.